Okay, so I'll get started with the optional information, and then people coming in late will be a little bit less intrusive. So welcome everyone. I'm here. This talk is brought to you by the Capacity Building team. If anybody does not receive the Capacity Building newsletter, you can let the lovely young lady know at the front desk, Alicia, and she will be happy to get you hooked up. We send out a newsletter monthly with information related to addictions and substances. And we also have a website that has courses you can take and all kinds of information. So if that's not a resource you're currently using or utilizing, Alicia's happy to get you hooked up with that. So welcome everyone. And today is actually really exciting for me because I feel like this is part two. We've got to a point where we're assessing and thinking about people's substance use is now a part of what we do. So now that we've ticked that box and we're doing that, how does that fit into our other assessments? Because I kind of feel like we assess in silos. You know, we do the assessment around risk, you know, we do our mental status, and then we do our addiction assessment over here. I think the challenge is what we know more than ever is that that addiction assessment can really impact suicide risk. And so what I'm asking you today to really think about is how can I really incorporate that addiction information, that knowledge I have around my client or patient substance use into my overall assessment of risk. And this presentation really has two parts. I'm going to talk for the first part, looking at some of the specific risk factors for suicide related to substance use. And, you know, some of these things are things we know and, you know, but just to really refresh us about really the fact that there's a lot of aspects of substance use that do put people at risk. You know, I'm going to talk very, very briefly about what we're doing from a screening and assessment process here at the hospital for probably about 2 minutes. But what I want to get to as well is it's fine to assess people, it's fine to identify, but how do we have those conversations? How do we, so we've got somebody, they've got some chronic thoughts around suicide, how do we have those conversations, you know, about that ambivalence? And the good news is the majority of you have already been trained in motivational interviewing, you've had some training around acceptance and commitment therapy, and if you haven't, you can. And I'm gonna actually spend some time kind of talking about how can you use motivational interviewing with somebody who has some ambivalence around living. And, you know, because given that's something we already know, or how could you use acceptance and commitment therapy to work with somebody who has some suicidal ideation? You know, because I'm sure a lot of us use dialectical behavioral therapy, but there's things that we already know because it's one thing, and I was actually recently at a conference where they showed about 5 really, really impressive studies saying that screening and assessment for suicide risk is everything you need to do. And then they showed another 5 that said it's a completely useless process. You might as well floss your teeth. And, you know, I think we're going to fly somewhere in the middle where we know it's very, very important. And that's why we've adopted a standardized screening assessment process. But if we're not getting to what's behind the pain, if we're not understanding that patient's story and we're not having the conversations, you know, anyone who's still alive has ambivalence about whether they want to live. And as long as people have ambivalence about wanting to live, then we have opportunity. And so that's really what we're going to be talking about today. And as always, my normal spiel, unfortunately, classroom education has zero effect on your clinical practice unless you take control of what you're learning. So pick the 1 or 2 things that you're actually going to use in your practice, write yourself a note, and check in with yourself. Otherwise, you might as well have gone for a Big Mac during this hour. So, you know, how are you going to benefit the patients that you work with by coming here today, which is why I know you're giving up your lunch hour to be here. There's a wonderful resource. And I actually have a bunch, and if you connect with Alicia at the front desk, we can arrange to get you one. This is a great resource. It's specifically looking at suicidal thoughts and behaviors for patients who have addictions. It's interesting because it's not focusing on kind of the mental health piece that we usually focus on. It's much more of a pure addictions kind of look at suicide. So that's a resource we can provide you with. So I'm going to start off by just giving you 3 really quick clinical scenarios. I've got 3 clients. I'm sure you have 1 or all 3 of these on your caseloads. So Gavin is a 55-year-old male. He's got an extensive history of alcohol use and depression. His drinking escalated after retiring 2 years ago, which is often common. He recently started volunteering, and that gives him a sense of being useful. He's drinking in a binge pattern Note how we've noted the alcohol, so 8 to 10 king cans of strong beer. So probably something that's about 7%. Really important in our assessments that we're really noting and looking at amounts, especially with alcohol, where there can be risk around withdrawal. He's recently stated that he lost hope that his life will get better, and he hunted in the past, and he has access to firearms. So that's your first person. Your second person's Molly. She's 26. She's got a diagnosis of borderline personality. She's got an extensive use of alcohol, opioids, and benzos. There's a past history of significant trauma. She's got 3-year history of self-harm, 15 admissions due to overdoses. Her mother has custody of her 3-year-old daughter, and Molly has access, and she generally doesn't miss any visits. And then we've got Max. He's a 45-year-old. He's got a 7-year history of couch surfing. He's homeless. He talks about wanting to work. He's got a diagnosis of schizoaffective disorder, extensive history of crack use. He's recently stopped injecting. He's got 2 recent suicide attempts where he was removed from high buildings during periods of depression. He recently, his substance use has recently decreased. He's attending NA, he's made some friends there. He's got a close relationship with an outreach worker named Quinn. His father completed suicide. So these are the 3 people. What I want you to think about is based on everything you know about suicide risk. Who do you think is at higher risk? So you've got 3 choices. We've got Gavin, we've got Molly, or we've got Max. So who thinks that Gavin is at highest risk? Okay. Who thinks Molly's at highest risk? Okay. And who thinks that Max is at high risk? Okay. How many people didn't answer? Okay. So you're right, because no idea in hell. I mean, that's really the answer. I mean, risk is one of those things that fluctuates, and I think that that's why it's really important that we're always really assessing everyone in front of us. All of these patients have both protective factors and risk factors, and I think that's one of the things that we always have to keep in mind, and I thought it was really interesting that most people didn't pick Molly as the person who was at highest risk, because we often think about that chronic picture with borderline personality, the person's not going to die from suicide, when in fact there's actually very high rates of suicide and death by misadventure. So I think I'm going to be referring to these 3 people later on when we talk about how to apply the interventions we know. So always important to keep in mind, individuals that have alcohol use disorder, 10 times greater risk for suicide. People with substance use disorder, 10 to 12 times. Individuals who inject, 14 times. Really, really important, if we're not capturing in our assessments people who are injecting at any point increases risks for poor outcomes. So even if somebody is not injecting currently, if they have injected in the past, it increases risk. So it doesn't mean they're going to necessarily have a bad outcome, but that's important information that we always want to be capturing. And of course, co-occurring mental health issues increases the risk further. So, in my assessment of someone's substance use, what are some of the things that increase risk for suicide completion? Definitely types of substances used. A lot of evidence coming out right now about increased suicide risk with opioids, especially during withdrawal. And I mean, the explanation is very simple. Opioid withdrawal is like the worst flu you've had in your entire life times 1 billion, and then times 1 billion that again. And feeling horrible, like there's no hope, and like your horribleness will never end, puts you at risk for suicide. And that's really speaks to the risk with opioids. And keeping in mind that withdrawal for opioids does this. It's really severe, then it tapers, but then it has a tail and it comes up again. So often we catch that initial withdrawal that people are going through, but we often miss that tail. And so, and again, another really important reason, if we're not referring and encouraging our clients to look at addiction medicine options, there's actually a study that just came out looking at how addiction medicine can actually decrease risk for suicide. So definitely something to think about. So the combination of substances, specifically the addition of alcohol, the amounts used, the severity of substance use. Are we talking about misuse? Are we talking about dependence? The duration of use, intoxication. Intoxication and withdrawal both pose increased risks for different reasons. So really thinking about the risk during that time, and of course, injecting substances. So In terms of alcohol-specific risk factors, so why does alcohol increase somebody's risk for suicide? So it often increases their psychological distress. People become more aggressive. This is one of the really important points. It really increases the likelihood of the translation of ideation into action. So it increases the risk that somebody will act on that ideation, but at the same time, it constricts people's ability to apply cognitive strategies. So when you think about those two things, I'm more impulsive and my ability to apply any problem solving has been decreased. That is the point, that is really that part of intoxication that puts people at risk. And acute alcohol intoxication is present in about 30 to 40% of suicide attempts and completions. So again, really, really important when we're working with somebody, and just to plug the RAM clinic again, 70% of the clients we're seeing at the Rapid Access Addiction Medicine Clinic are actually for alcohol. So if you're working with clients who are alcohol dependent and have struggled with alcohol, please look at exploring addiction medicine options because there is evidence. It's not something that we're necessarily always using here at this hospital, and it's something that can definitely lower risks for people. This was one of the things I found really fascinating. So these are the risk clusters in general used to look at risk for suicide. And if we look at the risk clusters, and this was not specific to alcohol or drugs at all, but alcohol or drugs, bless you, alcohol or drugs actually factor in to 4 of these risk clusters. So this is a really helpful kind of diagram because it speaks to, what are the combination of things that can put people at increased risk. And when we think about it, we probably often have clients that have all of these things going on at the same time. It's not unusual to have someone who's got an alcohol issue, stressors, recent crisis, legal issues, and is intoxicated. But just really important to really think about, some of these risk clusters, especially when these things are happening together. One of the other things in terms of drug-specific risk factors is definitely the intense feeling of depression that happens during withdrawal. And we talked a little bit about this with opioids, but we often see this a lot as well with crystal meth. So there is crystal meth withdrawal results in severe depression. The lengths of the period of depression increase with use. And so there's starting to be some work specifically looking at suicide risk during that time, especially for people that have used crystal meth for longer periods of time. And then one of the really challenges we're seeing right now is with the opioid epidemic we're having, is it suicide or overdose? And, very sadly, there's lots of times where we don't know. And, in terms of being able to look at situations and learn and make changes to our practice, we're really not sure what happened. So polysubstance factors are also a significant risk. And when you think about it, often the general chaos in one's life increases when one's using multiple substances. So I don't know that one can say that it's only because someone's using polysubstance, but it certainly is associated with higher risks. It's interesting because a lot of the early literature actually pointed to women who had polysubstance use being at higher risk for suicide than males, which would be really interesting because that's not the case in any other literature. But in looking at those studies, they actually, there's a lot of flaws. So it's difficult to kind of say, but the risk does increase significantly for women with polysubstance. So often something to think about. So comorbidity and suicide. So, one of the things I really wanted to draw your attention to with this is just, we've got thoughts, plans, and attempts. And when we've got, of course, co-occurring mental health and substance use disorder, we're looking at an increased risk. And this was fairly recent from 2011. So just, and I think the reminder with this too is, often, sometimes we mislabel, we decide that talk about suicide falls into behavior. Everything's behavior, breathing's behavior. And I think it's really, really important that, we remember that talking to people about the ambivalence is always something that can be helpful. And as long as you're alive, you're ambivalent. So One of the things that I found really interesting, and I think every time I put a presentation together, I always learn a number of things, or it reminds me. Sometimes it hits me over the head with something that I should know. And so what this slide looks at is substance use in diagnosis. And one of the things that really hit home with me was alcohol use in personality disorders. And this is specifically looking at borderline personality disorder. And I think a lot of us that work with this population, it's such a challenging population to work with that we don't necessarily focus on the substance. 78% of adults with borderline personality disorder also develop a substance-related disorder or addiction at some point in their life. That's huge. And it's generally not the focus of what we do. Often we just see it as part of the chaos. And so really, really important. One of the things that made me really excited when I read this, though, is that in studies looking at individuals with borderline personality that took addiction medicine medications, so took naltrexone or took methadone, there was no difference in the effectiveness compared to the general population. So that means that this population can benefit from addiction medicine just like any other population. And, often we're concerned to add to the chaos. And, this is just, a lot of the interventions that we use, despite the challenge of borderline personality, can still be effective. So I'm not going to focus on this, but just I find that some people aren't aware. Of course, anybody working on inpatient units is aware that we've adopted a consistent approach to the assessment of suicide, starting at the ED. So we are completing the screening tool in the ED, psychiatric emerge, and then it's continuing on the units. And we also are. This will be expanded to outpatient programs as well. And of course, we have a number of people that attend these sessions that aren't from St. Joe's. So just to review, the Columbia Suicide Severity Rating Scale, it's used as part of a comprehensive risk assessment. And again, a risk assessment is never a reason to throw out the rest of your clinical judgment. A risk assessment is simply one measure in addition to all the other skills. We don't employ robots that do risk assessments for a reason. So, always important to not forget everything else that you know. So I wanted to, and anyone from M1 will be familiar to this, when we rolled out across the hospital the algorithm around suicide screening and assessment, we specifically looked at M1 in terms of, our area where we have the most people populated together with addictions. And what is it that we need to specifically look at? And I want to walk you through this because, it points to some risk factors that we don't always think about, but also a modified process that can be used regardless of where your environment is. So, we have the Columbia. So the Columbia gives us some clues about risk. And then looking at other risk factors is really number two. Is the patient intoxicated? Is there withdrawal? Is there polysubstance use? Is there a history of injection use? So all those things we already talked about. And then we're also looking at some of the risk factors that we already assessed for. Is the patient currently or in the last 6 months engaging in self-harm? What we know about self-harm as a risk factor, because we have many patients who engage in self-harm, some who have suicidal ideation, some that don't, some that have very chronic thoughts about suicide, is really what we need to watch for is the chronicity of the self-harm. It's actually the chronicity rather than the brutality of the self-harm that tends to be more of the indicator. And sometimes we just kind of ignore, we've got someone who has engaged in self-harm for 10 years and that's just what they do. So really important to continue to monitor the chronicity of that self-harm is coming out more and more in the literature. So the other thing, of course, is really looking at, is there information being provided by family and other supports? And I know we all know that even when we can't give information, we can always receive information that's coming that could indicate risk. And also making sure for those of us that work on inpatient that we're reaching out to the outpatient follow-up, because often they're the people that see patients every day and may have clues around risk as well. The assessment of the environmental factors, this more pertaining to in-hospital. And then step 5 is the most important part of an assessment. So based on all this information, what am I going to do with it? What is it that's going to happen as a result of my assessment? If you assess and do nothing, you might as well not assess, because really you've identified risks and you've done nothing about it. I think the thing that used to annoy me the most as a manager is when I'd see a note saying, patient presented with this, identified manager. I'd be like, great. So you identified all these risks and you documented that you told me, and that's your plan. And so it's kind of like that, if we're not actually doing a step 5. So based on these risks, what am I doing? Is it affecting the legal status? Is my clinical monitoring going to change? For an inpatient, am I looking to access to means? Is this when, maybe I need to remove shoelaces or a cord? Clinical interventions. And then step 6 is, how does this integrate into treatment planning? So this is what we look at upon admission. And then these are the things we're looking at daily. And I want to draw your attention to something that we often ignore that can be a significant risk factor. And that is benzodiazepine tapers. Often benzodiazepine tapers are done very quickly. It's not unusual. We get someone on an inpatient unit. It's like, oh my God, they're on like 15 milligrams of Ativan. That's not very good. So let's taper that down really quickly. Because they're in a supervised environment, it's probably safe. Just because it's supervised doesn't mean that's not damn uncomfortable. So really keeping in mind, a benzo taper, if it's not done slowly, is incredibly uncomfortable. And in looking and reviewing, quite a number of studies have really pointed to benzo tapers. And it's not that we should have people on high levels of benzos, absolutely, and tapers are necessary, but we really need to ensure tapers are done in a way that's inhumane, really keeping in mind how uncomfortable that can be for the patient. So, I think this really speaks to, related to substance, what is it that I maybe am assessing on it when I first meet my patient? And then what are some of the things I'm looking at every day? For those of you not familiar with safe wards, am I looking at bad news? Is the person finding out they're being evicted today? Has there been any concerns raised by families? Again, looking at self-harm. So really kind of looking at what is it that I know about everything, including substance use, that I am using for my risk assessment, and how does that impact the interventions? And most importantly, how does that impact my clinical interventions and what I do clinically? Because really, we're not just here to identify risk, we're really here to provide an opportunity and a relationship for patients to tell their stories so we can understand the pain that's really motivating the thoughts about not wanting to be alive. And I think one of the things that I often do is, there's a lot of stigma for some patients about having thoughts of suicide. And what I often will say is, when people are really struggling, it's not unusual to not want to be here. And I'm just wondering, if you've had any thoughts about just wishing that you weren't here. And then I'm able to go and assess, do they wish that they're not here? Do they wish that they're not in pain? Or do they wish they were dead? Because those are 3 very different things. But I often will normalize that as human beings, we're driven by 2 very simple impulses, and that's to maximize pleasure and minimize pain. So it only makes sense when the going gets tough that we don't want to be here. And kind of that normalization often provides a platform for people to be able to have those conversations. And then that enables me to be able to assess, is this about not wanting to be in pain or about wanting to be dead? And that's really what we're doing in a risk assessment. So looking at our outpatient programs, one of the things we're looking at right now is for referrals coming into our outpatient programs. So whether you work at St. Joe's or not, any agency receiving referrals, how are we determining? Because we know that unfortunately we're not we don't have endless resources and we don't see referrals instantly. So you've got a big pile of referrals. How do you decide who's at risk? So again, in terms of the referrals coming in, what we're putting in place across the program is looking at, what does the Columbia say? Are there concerns raised by family? Has there been recent attempts? Is there a clear suicidal ideation? So based on that information, is there imminent risk Do I need to call 911? You know, I have COAST in there, but we all know COAST is not an emergency response. And if we're truly concerned about immediate risk, COAST is not who we'd call, it would be 911. Or is it that we need to see the client, we need to call the client within 2 days, and then based on that risk assessment, does the client need to be seen within 4 days? So not only looking at inpatient, but also looking at clients coming in terms of the assessment of risk. So that really looks at some of the specific risk factors related to addiction. So encompassing that in with everything we know about the risk factors around mental health, you know, we all know that there's many stressors that people go through. And often it's these secondary drivers. It's not the fact that I have a diagnosis, you know, it's the fact that I'm homeless, I have financial stress. And really, that's why we do the work that we do, to really help with some of these secondary drivers. So what we really want to do is, how do we utilize the interventions we know and some that we don't to support people in having conversations about their ambivalence? In terms of protective factors, a lot of these are things that people know. One of the things I want to draw your attention to is involvement in 12-step groups. There is more and more evidence that involvement in 12-step groups can actually decrease risk for suicide. And I think that probably speaks to purpose, community, all those things. And I know that's not always necessarily, for people that don't work in addiction-specific programs, something we think about. You know, and how I introduce 12-step is, because I find people will be like, oh, I don't like the God part. I'm like, you know what? 12-step meetings are like a buffet. You go, you take what you like, and you leave the rest behind. And, you know, I think there's often good things that people can get out of it, and it's certainly worth encouraging people to explore this to see if it's something that's helpful for them. So in some of our programs, we're currently doing something called the CAMS, which is the Collaborative Assessment and Management of Suicidality, and this is something that anyone can get training in, and it's something we're actually looking at, how could it be expanded to inpatient units to really help have those discussions. What I love about the CAMS is it's really about a collaboration between the patient and the staff, the clinical staff, to work together to assess risk and come up with a plan, and also to have an ongoing dialogue. And, you know, it's not just simply based on the expert doing the assessment, it's also empowering to the client in terms of the client learning to understand some of their risk factors. You know, it's really about clarifying the action that the client want to take, and also giving them a chance to participate from the treatment as well. So this is something that if you don't have training for, that training does come, typically often done in outpatient settings, but there's actually a couple of studies indicating how CAMS can be done in inpatient settings as well. PARS is a group model that there's more and more group models about, and this is really, PARS is specifically looking at preventing addiction-related suicide. And it is a group-based module. It's provided to clients once. It's 2 or 3 hours. We actually called the individuals that have developed it. And it's delivered directly to clients, and it's providing information directly around addiction and suicide. And it's interesting because a lot of the staff that were trained in this model were not psychologists. They weren't social workers or nurses. They didn't have extensive clinical training. You know, there were people that worked in community settings that were really interested in what could we teach our clients and support them in learning. And the outcomes, this is just one study and they've done further. So in a pilot of 78 clients, there were significant post-treatment changes in knowledge and attitude towards suicide prevention. Significant gains have been maintained at the 1-month follow-up. I'm always interested, 1 month, they're actually doing a 6-month follow-up. So this is actually something we're looking at, whether it makes sense for some of our outpatient programs. We actually talked to them about the possibility of training, so it might be something that we will look at for the future. But it was really interesting, and I was able to look at a draft of the material, and it was really geared on a client level, and the engagement from clients was really quite interesting. So in terms of other skills, many of us have been trained in motivational interviewing. And so I went to the literature just to look at, so in terms of motivational interviewing, what evidence is there to support using it for clients that have suicidal ideation? And of course, if somebody is presenting with a plan and all the risk factors, I'm not going to employ motivational interviewing, but we work with lots of people that, present with ambivalence about whether they want to live or die. So a number of studies have showed that the application of MI can really increase insight, that it can be helpful in helping change patients' level of ambivalence, and also helping them increase levels of self-determination and motivation. So quite interesting, and lots of studies supporting the use of motivational interviewing. And really, it makes so much sense because motivational interviewing is about exploring ambivalence. And again, suicide is about ambivalence. So how would you do that? So for anyone who doesn't know, motivational interviewing, client-centered style of counseling that helps clients explore and resolve their ambivalence about changing. So I was thinking about the clients we talked about earlier, and how would you use motivational interviewing? So in terms of reflective listening, and reflective listening is simply just showing that we understand someone's meaning. So if someone walks in and says they've had the worst day, it's been awful, I might say, sounds like it's been really tough for you lately. And they say yes, or maybe they say no, it hasn't at all. But again, it gives that chance to validate. And one of the reasons that I really like reflective listening is the feedback we've received from a lot of clients is that because clients notice the fact they're being assessed for suicide much more often than they were before. And, they talk about how they feel like they're just being asked these questions. And what I thought about is how it would be very easy to incorporate validation of feelings into assessment. So, keeping in mind, for those of you that work with individuals with psychotic disorders, we work with people who we don't necessarily agree with the reality they perceive, but what we do is we validate the emotions. We validate that it's frightening. We're not validating necessarily that we see the same reality, but we're validating that human emotion. And what I'm really thinking is that reflective listening, so I'm assessing you, I'm asking these questions, and you're saying, yeah, I'm having these thoughts, and I might say, wow, it takes a tremendous amount of courage, to have these conversations with me. I'm hearing that must be really frustrating, but really starting to validate that emotion. And we actually had some conversations on one of the units, and someone said, well, isn't that kind of reinforcing? And I'm like, it's one thing to be reinforcing, if I'm going to talk to somebody about their superficial cutting for 2 hours, it could be reinforcing. But simply talking to people about their emotions and validating that their emotions are real is an evidence-enforced intervention. So really thinking about when I'm doing all these assessments, when I'm asking all these questions, how do I actually incorporate reflective listening? How do I reflect back what I hear? But most importantly, with reflective listening, it's reflecting back that emotion. It's reflecting back, that real meaning. And one of the tools that I think is most effective with this is really that double-sided reflection. Because again, what we're looking at is ambivalence. So life sucks, I just can't see anything getting better. I wish I had the courage to end things, but it would really hurt my mom. On one hand, it sounds like things are really difficult for you right now. Yet on the other hand, I hear there's someone in your life who's important to you. So being able to use that to kind of show the ambivalence. Because what we want to do with that is then really start working on that other piece, which is important people in their lives. Because that's about meaning. And what do we know about meaning? Meaning is a protective factor for suicide. So really working on that meaning side of the ambivalence in order to help people see that other side. So I really encourage you to pull out your motivational interviewing stuff and really think about, in terms of all the other tools that we use into having these conversations, how can I use some of my motivational interviewing skills? And I was thinking about, as I was putting this together, about change talk. And change talk is often something we listen for around changes in substance. Do we hear desire? Do we hear ability and reasons and need? And I was thinking about our earlier examples and our our young woman, Molly, who has a daughter that she cares about. Well, that could be seen as an argument for change. The fact that she's actually going to those visits can be seen as taking steps. So there's ways to incorporate this change talk when we're working on this ambivalence about people wanting to live. How do we work on and use those same skills and listen for that change talk? And really, this would be looking for ambivalence about wanting to live. So these are just a quick little review. What's really important is in any change, I might have all the desire in the world. I may have some ability. There might be reasons and there might be need, but we also want to really reinforce, do we hear anything about commitment? Are people talking about a step they took? Because we really want to hone in on that and give people the opportunity to hear themselves speak about that. Because what we want to really raise is that commitment to making that change and also the taking steps and the action taking. So just a really quick example of how you can use something you already know to have these conversations. And as many of you know, I absolutely love acceptance and commitment therapy. My mother thinks that it's a cult that I belong to, which it is not. I have to say I was actually at an ACT conference recently and it was a little bit cult-like, but that in a good way. So it's kind of like all the people that don't follow the rules like this therapy. So in acceptance and commitment therapy, there's been quite a number of studies really looking at, and it's interesting, in this one they actually used the Columbia as one of their rating. And most of the studies have been done in groups, and what they saw is they saw decreases in psychological pain, hopelessness, and anger, and really through its effectiveness in reducing suicidal ideation and improving the clinical dimensions associated with suicide risk in patients suffering. And what acceptance and commitment therapy really looks at is increasing psychological flexibility. Psychological flexibility is the ability to work towards what's important to me, despite what's sticky and what might get in the way. So, thinking about, having a client in front of me, and thinking about somebody who is ambivalent about whether they want to live or not, one of the first things we look at is contact with the present moment in ACT. And, often when people are suicidal, it's not because of necessarily only what's happening today, but we get hooked by the past and we get hooked by the future. And think about yourself. Think about the worst moments you've had. Chances are you're not just in that room, you're in like a time that happened when you were in 6th grade, you're in your worst breakup, you're in some time that you were humiliated, and I think except often when people are feeling at their worst, it's because they feel like they're watching a movie of all the worst moments of their life. And one of the best things we can do with acceptance and commitment therapy is help people use mindfulness techniques to actually get into this present moment. And that's the amazing thing about ACT, is it's not about sitting in a room saying for 30 minutes and meditating. It's about actually using mindfulness techniques. Even simple, I have people brush their teeth mindfully in the morning. Put your toothbrush in your mouth. Only focus on how the toothbrush feels and the taste. Your mind will go all over the place. Acknowledge thoughts, direct to your toothpaste, to your toothbrush, and start your day sending your brain the message that you're the boss, that your thoughts, feelings, and emotions are not. So, even talking to people about getting that contact with the present moment. Suicidal ideation is often about losing touch with values. Often when people are in despair, they've lost complete touch of what's important to them. They can't even think about it. And it's important. Often I don't use the word values with people, especially when they're in despair. I talk about what's important. And I think the reason that we look at values is so that we can look at what people want to commit to. And what I often phrase that is what do you want your life to be about? And when you think about it, ambivalence about whether to live or not is completely about not knowing what you want your life to be about. One could argue that probably is what's contributing to feeling suicidal. So really looking at, and sometimes the idea of committing to your whole life is huge. And I talk about, what do you want the next 5 minutes to look like? How do you help people get a sense of mastery over the next 5 minutes? Because again, increased mastery, decreased risk in suicide. So really looking at how are we using some of these concepts. The self is context. We often tend to function, think about it this way. We tend to function like we're the weather. We function like we're the stormy day, we're the rain. Those are the things. We're actually the sky. We're that huge expansive thing that can contain all these things. We're a container for our emotions. We're not the actual emotions. I often talk to clients around, imagine a really, really, really strong house that's been painted and renovated 10 times. Guess what? That's the same house. So it doesn't matter what you've been through. It doesn't matter how beaten down you feel. And I hear that and I always validate that many times. You know what? Those structures, those pieces of you, you're that same house. Because often we tend to take on the paint color. So being able to help people develop a different relationship with their thoughts, feelings, and emotions, which is what we do through diffusion. So having people start to observe, having people observe, I'm having thoughts that life might be really shit. Okay, and I often will say to people, I want you to think about, 20 thoughts you've had today that would probably have you arrested. And they always laugh. And it's like, so think about all the thoughts that you have in a day that you don't act on. So just like you don't act on those thoughts, isn't that tremendous power? Because that means that you have complete choice over what thoughts you do act on. And being able to turn that around and give clients that power. And many of you that have been to my act hear me joke about my forever wish that smoking was good for you. There is nothing I wish more than smoking didn't kill you. I love cigarettes. I still think about smoking every day. I don't anymore. But, at least 7 times a day, I stamp my feet in a bad day and I'm like, damn, I'm having thoughts about wanting to smoke. Yeah, just like I have thoughts about lots of things that would put me in jail, but I don't do them. And so learning to put that space, learning to notice. So it's like I'm observing my thoughts, feelings, and emotions. I describe them, and then I make a choice about whether or not I want to act on them, rather than being that automatic acting. And having people start to have that observing relationship rather than that action relationship. And so even something simple like this gives us the opportunity to, be able to have those conversations about ambivalence. So just a quick review, clients are ambivalent, and if we were all honest, there's times that everybody feels pain and everyone wishes they didn't have to deal with things. And I think what we're really doing, again, is assessing that ambivalence about pain or ambivalence about being dead. Almost all clients, and suicidal crises can be overcome. And although suicide can't be predicted with certainty, risk assessment is important. However, being assessed is also annoying. So please remember, for every assessment you do, we're also using our clinical interventions to have those conversations and at the same time validating those feelings. Thanking clients for asking our questions. I can't imagine how annoying I must be. Thank you so much for giving me those answers. Again, being appreciative and recognizing that impact that we're having on someone by making them answer our questions. I think if I could eliminate anything in our system, I think it would be that repetition. I often wonder how many times do people repeat their information even in one day on one unit? So, just validating that, I can validate that we have really frustrating processes, which I often do. It doesn't mean I'm saying you don't have to do it, but I'm validating that, yeah, it is really frustrating that we have to do this. Suicide attempts must always be taken seriously, and I think especially, when we're working, taken seriously doesn't necessarily mean that that we're focusing and having that conversation about that attempt, but it's really important in terms of our overall assessment. And of course, best to ask clients about suicide directly. It's still amazing the number of people that actually think that talking about suicide with somebody increases risk, just like the number of people that think that talking about self-harm increases self-harming behavior. Obviously, if we're going to talk about someone's actual superficial cutting for hours and hours, it's probably not helpful. But having those conversations about the emotions and about things that are helpful, is not reinforcing of any kind of behavior. And most importantly, the outcome does not tell the whole story. And sometimes really sad things happen And, you know, I think we were having a conversation on the outpatient programs, and I said, just because really sad things happen doesn't mean you did anything wrong. You know, I think we're always, you know, I think one of the most difficult and probably personally developing situations I ever went through actually was when I was on the ACT team years ago, and I had a client who came in particularly high risk, and I was actually doing his tools for treatment, and he was going to come back, and he didn't. He actually went home and completed suicide. You know, and I think that was something that sat with me, and you know, I probably didn't get the help I needed to work through it for years later. And I actually was presenting at the social work department at MAC, and a student stopped me and said, "Can I ask you a question?" I'm like, "Sure." And she's like, "Do you think you did anything wrong?" And I said, "I don't think I missed anything that would have changed the outcome, but it's forever changed how I see people's pain and how I assess people." And really, when we think about suicide assessment, you know, it's not just about assessing risk. It's really about exploring ambivalence, and it's really about, you know, instilling hope and giving people that opportunity. One of the things that I didn't have time to do a really thorough kind of dive into, but there's lots of really interesting studies looking at narrative therapy in terms of helping people tell their story, and also looking at art therapies as well in terms of mediums for people that aren't necessarily as verbal. And just one point before I close, gambling has not been the focus of my presentation, but just very, very important that we're always assessing for gambling. Gambling puts people at very significant risk for suicide, and it's often not something that's included in our assessments. I believe on the capacity building website, there's a very short module that pertains to gambling, but just something that's very important to be including in our assessment. So that is, oh, and I'm on time. So that is the end of the presentation that I have. I am open for any questions. And I also, between Alicia and I, we can arrange to get you that book that I mentioned that we have copies of. Okay, I'll stick around for the next 5 or 10 minutes. Thanks everyone for coming, and we look forward to you at the next education session.